Good morning. I am MST Shamimara Begum, one of the students from Western Sydney University. According to National Heart Foundation Australia, more than 1 in 10 people of the age of 75 and over are affected by heart failure. Acute exacerbation of chronic heart failure causes significant burden on the healthcare system. Today, I will discuss the clinical manifestation of acute exacerbation of chronic heart failure and the underlying pathogenesis causing the clinical manifestation based on the case study of Mrs. Brown. The diagnosis of acute exacerbation of chronic heart failure is based on cardiac and respiratory symptoms and signs of the patient. I will first focus on the respiratory signs and symptoms, then I will focus on the cardiac signs and symptoms. The first respiratory symptom which I want to discuss is severe dyspnea experienced by Mrs. Brown. In heart failure, due to reduced myocardial contractility, left ventricle cannot eject blood effectively in the systemic circulation, resulting in decreased cardiac output and an increased accumulation of blood in the left ventricle. Elevated left ventricular filling pressure causes backward transmission of blood into the pulmonary circulation. This in turn increases pulmonary capillary hydrostatic pressure. This increased pulmonary capillary hydrostatic pressure causes consolidation of fluid into pulmonary interstitial tissue and alveoli. When the flow of fluid exceeds the lymphatic system's ability to remove excess water, fluid accumulates in the lungs, resulting in the development of pulmonary edema. As a result, gas exchange ability of alveolar capillary membrane is reduced, which contributes to the feeling of breathlessness. Reduced cardiac output also causes reduced blood flow available for gas exchange, which in turn makes the patient short of breath. Now, I want to move on Mrs. Brown's SpO2 of 85%, which indicates low capillary oxygen saturation. In heart failure, development of increased pulmonary hydrostatic pressure and pulmonary edema lead to swelling of the alveolar capillary membrane, which reduces gas exchange ability and thereby reduces oxygen content in peripheral circulation. I would like to draw your attention on another respiratory sign of bilateral basal crackles, which was found on Mrs. Brown's chest auscultation. This is because of pulmonary interstitial and alveolar edema resulting from backward failure of the left ventricle into the pulmonary circulation. Increased pulmonary capillary hydrostatic pressure causes movement of the fluid from pulmonary capillary into the alveoli. Last respiratory sign for Mrs. Brown that I want to focus on now is respiratory rate of 24 breaths per minute. As a consequence of dropping of oxygen level in blood, tissue become hypoxic, which is sensed by peripheral chemoreceptor located in the carotid and aortic body. Peripheral chemoreceptors become activated and send afferent signal to the respiratory center to increase the rate and depth of respiration. As a result, patient become tachypneic. I have discussed the respiratory signs and symptoms. Now I want to move on cardiac sign of heart failure. From the case study, we can see that Mrs. Brown is tachycardic at 120 beats per minute. Myocardial dysfunction in heart failure leads to a decreased cardiac output, which results in activation of baroreceptor located in the left ventricle, aortic arch, and carotid sinus. Activation of baroreceptor causes stimulation of vasomotor regulatory center in medulla. Stimulation of vasomotor regulatory center causes activation of the sympathetic nervous system, which in turn increases the heart rate by releasing catecholamine. Finally, I want to focus on Mrs. Brown's blood pressure, which is elevated at 170 over 95 millimeter of mercury. One of the hormonal system which is activated in response to reduced cardiac output in heart failure is the renin-angiotensin-aldosterone system. Reduced renal perfusion because of low cardiac output triggers the release of renin from juxtaglomerular apparatus. Renin catalyzes the conversion of angiotensinogen into angiotensin 1 in liver. Angiotensin 1 is then converted into angiotensin 2 in the lung parenchyma. Angiotensin 2 is a potent vasoconstrictor which increases peripheral resistance and thereby increases blood pressure. In my presentation, I have covered clinical manifestation of Mrs. Brown, who was diagnosed with acute exacerbation of chronic heart failure. According to the clinical manifestation, Mrs. Brown is not in a stable condition and needs critical review. Thank you for listening.